So as I was saying, I work primarily out of Francis Perry and the Royal Women's. I do also consult at Masada in St Kilda East and also at Hawthorn East Specialist Centre. I'm very happy to see patients there as well, but I do all my deliveries at Francis Perry House. Now my practice, unlike Chin's, focuses primarily on obstetrics, especially high-risk obstetrics, and I have a very key interest in preterm birth and its prevention, and that's what I'm going to talk to you about tonight. Essentially, preterm birth is something which I'm quite passionate about because I think it's a really important yet challenging part of obstetrics. Not only challenging because there is a lack of international consensus about how to manage women at risk of preterm birth, but equally because it's dealing with women at a very, very vulnerable time for them. They've often had very difficult, traumatic previous obstetric experiences, and the continuity of care that you can provide in the area is really, really important and rewarding. When you're thinking about preterm birth, and what I'm going to talk to you about tonight is not only sort of the statistics of preterm birth or the evidence about preterm birth, but remembering that there's a very human and personal impact that preterm birth has on women and their families, and that's something which I think is actually highlighted very nicely by a video that I'm going to show you now. The video has been produced by the Women and Infants Research Foundation in Western Australia, led by John Newnham, who's very well known in this field, and I think it highlights perfectly why I find preterm birth to be so interesting.
In, I think it was October, we got the news that I was pregnant, which was fantastic.
I had the perfect pregnancy.
We'd had a very routine, well we thought was a routine pregnancy, and then at 31 weeks I had what they called a hind water leak.
And then they decided at 7 p.m. they were going to fly me down with the Royal Flying Doctor Service, and I left Port Hedland about 9 p.m.
And at my 24-week checkup, the obstetrician noticed my blood pressure was high.
Then 1 week and 6 days later, I had a bit of a leak, and I thought, oh.
I was admitted to King Eddie's and I was in there for 4 nights.
At 24 weeks, my waters broke for not sure why, and I was rushed to King Edward's Memorial Hospital and put on straight to bed rest.
I thought I was just going to be on bed rest for the next 10 weeks and he'd come full term. But it didn't work out that way.
Anyway, on the night before she was born, I got really sick. My membranes, my waters had an infection, and I was going downhill pretty rapidly, and the call was pretty well made that, okay, we need to get Stella out.
He was born at only 500 grams, so there were a multitude of issues to deal with. And day 1 of his life he was diagnosed with a bleed on his brain.
He had been diagnosed at 19 weeks with only half a heart.
No one should go through it if they can't. Like, I wouldn't wish this on my worst enemy because it's just, it's so emotional and so hard. Oh, sorry.
They came down and said that she wasn't doing very well and didn't want to get it baptised. Sorry.
Can't even describe it. I just love going in there, spending as much time as I can with him.
When she came out, she had to go straight down to the nursery and get all these tubes put into her and IV lines, and yeah, it took me nearly a day to be able to see her.
I had no idea about preterm birth at all. I didn't have any family, any friends, anyone I knew about preterm birth. So
Just every extra day of baking time in pregnancy can decrease your chance of risks.
And I was able to prolong the pregnancy to 28 weeks. It would be phenomenal to let people know more about how to avoid preterm birth.
We need your support. We need to save these babies' lives.
We need your support.
We desperately need your support.
Please support us.
We need your help.
We need your support. We need your help, and we need it now.
I certainly find this quite a powerful video, and I'm sure a lot of you do as well, and I think it certainly has motivated me to continue to work in this area, and I'm hoping that tonight I can sort of make things understandable at a level that will enable us all to work towards preventing preterm birth. So essentially moving on to preterm birth. So preterm birth is any birth prior to 37 weeks gestation, and essentially it can be subcategorised into extreme, very and moderate to late preterm birth, broken up into sort of gestations of 28, 32 and deliveries thereafter. And we know in Australia consistently every year approximately 8 to 9% of babies are born preterm, and that sort of compares very favourably with a statistic worldwide of just over 11%. Why does preterm birth occur? For the purposes of this evening, I think it's important that we break preterm birth into two categories. There are women who go into spontaneous preterm labour. These are women that either labour preterm or rupture their membranes preterm or have cervical insufficiency. And then there are a group of women that are delivered early on medical grounds, so iatrogenic or medically indicated preterm birth. Now, the most common reason for this is probably preeclampsia or hypertensive disease in pregnancy, but other common causes include fetal growth restriction, antepartum hemorrhage from things like either placental abruption or placenta previa, any deterioration of a pre-existing medical condition. The most common ones here would be pre-existing diabetes, renal disease, or any autoimmune disease like antiphospholipid syndrome or lupus, or multiple pregnancy. And the current recommendation is actually that all monochorionic twins are delivered preterm, so prior to 37 weeks gestation. And that is sort of has increased the incidence of preterm birth as our rate of multiple pregnancy increases as well. And obviously spontaneous preterm birth tends to be more common. It sort of accounts for about 2/3 of cases, while iatrogenic preterm birth accounts for the other third. Why do we worry about preterm birth? Well, I think as we've seen tonight, it matters on a personal level, but equally, babies that are born preterm experience significant potential complications early on and throughout their lives. Preterm birth actually accounts for 70% of all neonatal mortality, and we know that the mortality rate, as I'll come to shortly, increases as the gestation decreases. And 40% of childhood neurological morbidity is attributable to preterm birth. So most of the best data we get is from the ANZNN, which is the Australian and New Zealand Neonatal Network, and they put a publication out sort of every 12 months. The most recent one that we actually have access to is their publication from 2015. I'm just going to highlight a few important statistics that have come out of this publication. So in terms of survival to discharge, we can see that prematurity significantly increases the risk of death for an infant essentially. And prior to 24 weeks, so now if you go to any tertiary centre in Australia, most tertiary centres are resuscitating babies from 23 weeks gestation now, okay? So 23 weeks is now considered viability. Obligatory resuscitation occurs from sort of 24 to 25 weeks, depending on where you're working, but almost all parents in a tertiary centre in Australia will be given the option of resuscitating their baby after 23 weeks. So at 23 weeks, how many babies will survive to discharge? The number is only just over 50%. By 24 weeks, it's up to 70%. It's up to 80% by 25 weeks, 90% at 26 weeks, with small incremental increases in survival each week thereafter. A really important morbidity that we need to look at is intraventricular hemorrhage. And again, we can see that at babies born at 23 weeks, they have a rate of IVH of above 60%. It goes down quite significantly at 24 weeks to 45%, and by 26 weeks, the number is at about 25%. Functional impairment is really important because a lot of parents ask, okay, I understand you're telling me my baby will survive, but how well will it survive? What is its level of functional impairment going to be? And we tell women that at 23 weeks, only 45% of babies that are born will survive intact. That is with no degree of functional impairment. Functional impairment includes cerebral palsy, motor, cognitive and language delay, as well as sensory issues with hearing and vision. And we know that that number decreases quite significantly by 26 weeks and small amounts thereafter. There are lots of other sequelae of preterm birth, which I won't go into detail about tonight, but essentially there are much higher incidences of respiratory distress syndrome, necrotizing enterocolitis, skin problems, infection, cardiac abnormalities, especially issues with patent ductus arteriosus, significant hearing impairment, and retinopathy of prematurity, which actually affects up to 85% of babies at less than 28 weeks gestation. It's very important also, I've sort of focused on babies born at really premature gestations, but what about the babies born at late preterm gestations? This is something which must not be dismissed because babies born even at 34 to 37 weeks still have a much higher incidence of overall morbidity and neonatal death. There are issues with hypothermia, hypoglycemia, feeding, breathing difficulties, primarily respiratory distress syndrome and mechanical ventilation. There's a higher incidence of jaundice requiring phototherapy, and these babies absolutely have a higher incidence of long-term neurodevelopmental delay. New research has also come out in the past couple of years which suggests that women who deliver preterm have an increased risk of medical conditions themselves over their lifetime, with an increased risk of ischemic heart disease, stroke and overall cardiovascular disease. So as you can see, the effects of preterm birth are vast. So tonight I'm going to break the talk into two parts because they're quite separate. The first is spontaneous preterm birth, and later I'll talk about iatrogenic preterm birth. So this is a referral that I've received from a GP, and I think it's an idea of what sort of things are useful to be sent to someone who specialises in preterm birth prevention. So this referral is about a patient who essentially in 2013 had a pregnancy loss at 21 weeks. The baby was stillborn in the setting of what was almost certainly cervical insufficiency, so presented with painless cervical dilatation and went on to spontaneously deliver the baby. And then a year later, after another spontaneous conception, delivered her baby at 31 weeks. Now this lady's child, who was born at 31 weeks and has survived, does have cerebral palsy. So what are the factors that increase a woman's risk of going into spontaneous preterm labour or spontaneously delivering a baby early? The main risk factor to consider is a previous preterm birth, especially if it occurred prior to 34 weeks. The relative risk for preterm birth prior to 32 weeks in a woman who's had a preterm birth previously is 6. And recurrent preterm birth overall occurs in 30% of women, but it's up to 60% actually if this woman has had 2 preterm births previously. So in a woman like I've highlighted by this referral, she has a 60% chance of a subsequent preterm birth. Of note, any preterm birth in the obstetric history is protective. That is, it decreases the risk of preterm birth in a subsequent pregnancy, even in a woman who has had a preterm birth. Other risk factors include a previous mid-trimester loss, which was thought to be secondary to cervical insufficiency, cervical procedures, which I'll touch on further in a second, but a cone biopsy is a significant risk factor, and at least 2 LETSs or ablative cervical procedures, that is laser, increase your risk. A woman who's had at least 3 cervical dilatations is at a high risk, so this might be for a miscarriage or a termination of pregnancy or a hysteroscopy of DNC. It's not uncommon to see women that have had 3 miscarriages, have had 3 curettes. These women are at a high risk of preterm birth and need to be referred on. What was that? No, not to that degree of dilatation, it shouldn't. Congenital uterine malformation, so that's even a bicornuate uterus, which is relatively common in our population, and any obstetric cervical trauma, so any woman who says she had a cervical tear with a previous pregnancy that was repaired. Just going back to cervical procedures in preterm birth, we have very clear evidence that a cone biopsy, so a cold knife cone, is associated with a much higher risk of preterm birth. The relative risk is almost 3, but we do know that a single LETS or laser ablation is not consistently in the research associated with an increased risk of preterm birth prior to 34 weeks gestation. So how do we manage women who are at an increased risk of spontaneous preterm birth? We have 4 options, and I'm going to detail them all shortly for you. The first is cervical surveillance, another is progesterone, the third option is cervical cyclage, and the fourth is other medical treatment, most of which is sort of in the experimental phase at the moment, but I'll talk to you about it shortly. So let's look at cervical surveillance. Now, cervical surveillance is something which we do in dedicated preterm labour clinics, or people with a specific interest like myself do in our private rooms for patients. So cervical length, we know, has an inverse relationship with the risk of preterm birth. And what we can see from this graph is that as the cervical length decreases to under 20 to 25 millimetres, depending sort of on where you work and what study you read, the probability of preterm delivery increases. And this is the threshold that we're interested in. So it's cervical lengths of less than 20 to 25 millimetres. How do we perform cervical surveillance? So essentially, the way I do it is I see women fortnightly from 14 to 26 weeks. They have a transvaginal ultrasound at every visit with me for cervical length. Now, this is done with an empty bladder. The probe is placed into the anterior fornix of the vagina. We avoid any pressure because it can artificially sort of lengthen the cervix. And it's a sagittal view, as you can see here, from the internal os to the external os of the cervix. In addition to looking at the cervical length, we're looking at a couple of other things. One of those is funneling of the cervix, of the membrane, sorry. So funneling is where the membranes protrude into the cervical canal, and we can sort of see that occurring over here. And the other is the presence of intraamniotic sludge. Now, this is something which is coming to a bit more prominence lately. Sludge is thought to essentially represent subclinical intraamniotic infection. And in these women, there is no clear evidence for treatment. However, in a lot of institutions, we're using azithromycin intravenously for a week to try and improve the sludge and reduce that subclinical intraamniotic infection. And that's what we're seeing over here. This arrow is pointing to intraamniotic sludge. What is a normal cervical length? Well, again, it depends on what gestation you measure it at, but essentially the median cervical length at 20 weeks, which is usually when we'd be doing a morphology scan, for example, is about 42 millimetres. And at 24 weeks, the 25th centile is 30 millimetres, 10th, 25 and 5th, 20 millimetres. And as I said before, it's really sort of cervixes under the 5th to 10th centile that benefit most from intervention. In addition to performing the scan at each visit, I also do a speculum examination. And with each speculum, we do a high vaginal swab looking at the microscopy culture and sensitivity. Now, we test for a number of bacteria. However, the only one that we actually have really good evidence for treating is chlamydia, and this is not something that is always tested for. BV is very common and associated with a 6 to 7-fold increase in the risk of preterm birth, but unfortunately, treating bacterial vaginosis does not actually have a significant effect on reducing the risk. And we have very weak evidence for screening for and treatment of ureaplasma species, but this is actually something that we do routinely because of its potential benefit. The other thing we do at 26 weeks is perform a fetal fibronectin. Now, this is a test that a lot of you may not be familiar with, but for those of you who have sort of worked recently in obstetrics, you might have seen these done. So fetal fibronectin itself is a glycoprotein which is found between the fetal membranes and the wall of the uterus, and it's expressed in much higher quantities in the vagina in women at a high risk of preterm birth. So when I see women at 26 weeks, that is their last visit for cervical surveillance, I perform a fetal fibronectin. It has an excellent negative predictive value. It's very, very high. And I can reassure women, therefore, that if they have a negative result, that is a result of less than roughly 50, their chance of labouring within a fortnight is less than 2%. And we really use this to guide our management of women around that 26 to 28 week mark. The question, therefore, is if we know that, short cervixes, should be treated because of the risk of preterm birth, should we actually be measuring a cervical length in absolutely everybody? And the Australian Society for Ultrasound Medicine does recommend that we measure the cervical length at every woman at the time of her morphology scan, okay? And any woman with a cervical length of less than or equal to 25 millimetres should be referred for specialist care. I'll come back to this shortly. That sort of covers cervical surveillance. I'm going to move on to progesterone now. And progesterone is the flavour of the month in preterm birth, and it appears to certainly be important in maintaining uterine quiescence in the latter half of pregnancy. We do not know exactly how it works, but what we do know is there is functional withdrawal of progesterone activity at the level of the uterus, proximate to the onset of labour in both term and preterm babies. Now, when we are thinking about progesterone, I want to make this understandable, and the best way for us to do this is for us to consider the indication for progesterone. And there are two groups of women that should be considered for progesterone. They are women who've had a prior preterm birth and women who actually have a short cervix. So let's start with the women who've had a prior preterm birth. We, up until recently, had many studies which supported the use of progesterone in women with a prior preterm birth. So this was a big systematic review and meta-analysis done in 2012, which said that in women with a singleton pregnancy and a prior preterm birth, progesterone decreased the risk of preterm birth by 22% and neonatal death by 42%. There was another big study. This was a randomised controlled trial, I think, done using injectable progesterone. And again, it led to a significant reduction in the rate of spontaneous preterm birth in those with a history of spontaneous preterm birth. And delivery at sort of, as you can see here, 32 to 37, or less than 32 to less than 37 weeks was reduced by between sort of 40 and 45%. Very, very effective. We do not have injectable progesterone for this use in Australia, just so you're aware. This is used primarily in the States, and there's no good data that sort of allows us to extrapolate the use of injectable progesterone to vaginal progesterone, which is what we use here, but still this study very much supported progesterone. There was another study published in AJOG in 2003 which said that vaginal progesterone in women at high risk for preterm birth significantly reduced the risk of delivery by quite significant numbers as well. However, everything that we thought we knew about progesterone was disputed by a study called the Optimum study, published by Jane Norman and her team in the UK in 2016. This was a randomised control trial whereby women were randomised to either vaginal progesterone, 200 milligrams daily, or placebo, starting at 22 to 24 weeks and continued until 34 weeks gestation. And the inclusion criteria here were prior spontaneous preterm birth before 34 weeks, a cervical length of less than 25 weeks, or a positive fetal fibronectin with clinical risk factors. And what Norman and her team found was that vaginal progesterone did not improve the primary obstetric outcome, which was essentially fetal death or birth before 34 weeks. It did not improve the primary neonatal outcome, and it did not improve the primary childhood outcome. And she extrapolated this data to both women with a prior preterm birth and women with a short cervix. So she essentially told us there is no role for progesterone. What she did say though was that progesterone is safe and it does not increase the risk of any major complication in women or their offspring up to 2 years of age. Minor side effects only were noted. Having said that, in women with a short cervix, an excellent, huge meta-analysis has recently been published in February of this year, and it tells us that vaginal progesterone does decrease the risk of preterm birth and improves perinatal outcomes in singleton pregnancies with a mid-trimester sonographic short cervix. The primary outcome, which was preterm birth prior to 33 weeks, was reduced by about 38%. There was a significant reduction in a number of secondary outcomes, and again this study supported that there is no deleterious effect on childhood neurodevelopment. So, although Jane Norman's study said in women with a prior preterm birth there's no effect, we don't have any more recent data to go against that. In women that actually have a short cervix, the most recent evidence does say, yes, use progesterone. So RANZCOG summarises it beautifully for us, okay? And what they say is that vaginal progesterone therapy is recommended for asymptomatic women with a short cervix on transvaginal cervical length in the mid-trimester. However, in women who have a history of a spontaneous preterm birth, we can consider progesterone, but they do not entirely endorse its usage. And to be completely honest, whether or not progesterone is used in women with a history of spontaneous preterm birth really depends on the institution in which you work. Let's move on to cervical cerclage. So cervical cerclage can be done two ways. There are vaginal sutures and there are abdominal sutures. Vaginal sutures are far more common, and there are two types. There is a McDonald suture, and that's the top stitch that you're seeing here. Essentially, it's a purse string suture placed around the intravaginal portion of the cervix. And the second is a Shirodka suture. That's what we're seeing at the bottom. And a Shirodka suture involves reflecting the vaginal mucosa or the cervical mucosa in order to essentially allow the stitch to be placed higher. Now, there is no evidence that one type is better than the other, and I strongly suggest that a practitioner that does this uses a stitch that they are most comfortable with. And I am certainly a fan of the McDonald suture and have had excellent outcomes with it. For women who are not suitable for a vaginal suture, and these are women who've either had a failed previous elective vaginal suture or who have no cervix with which to work, so these are women, for example, who've had trachelectomies in the past, then an abdominal suture is your option. Now, these are being done currently in Melbourne laparoscopically. It is a suture that stays in essentially permanently, and because of that, it sort of means that a woman with an abdominal suture has to deliver by caesarean section. So when we think, she absolutely can, it does not affect conception rates. So who gets a cervical cerclage? Essentially there are three groups of women. There are women who have a history indicated cerclage, there are women who get an ultrasound indicated cerclage, and there are women who get a rescue cerclage, and I'll briefly touch on each of them. So who gets a history indicated cerclage? Any woman that has had at least 2 previous mid-trimester losses thought to be due to cervical insufficiency, or at least 2 preterm births should be considered for a history indicated cerclage. The suture is placed at 13 to 16 weeks, and this is for 2 reasons. Firstly, that highest risk of miscarriage in the first trimester has passed, and equally it enables us to perform aneuploidy screening in women who desire it, and for us to have results of this. Ultrasound indicated cerclage is something which we have relatively good evidence for in women with a prior spontaneous preterm birth and a short cervix. So as we can see from this study, in women who had had a prior spontaneous preterm birth and then on ultrasound have a short cervix, the risk of preterm birth and perinatal mortality is reduced by 40 to 50%. Having said that, we do not have as good evidence for cervical suture in short cervices in women with no history of preterm birth, okay? And both the Three Centres collaboration, which is a collaboration between the Royal Women's, Monash Medical Centre and the Mercy, and the Canadian guideline, for example, from the Society of Obstetricians and Gynaecologists, says that there is no benefit to cerclage in a woman who has an incidental finding of short cervix, but no risk factors. That, however, has been slightly disputed by another study. I know, the evidence is very, very difficult with preterm birth, and I promise I'm going to provide you with a summary very shortly. But essentially, this study, which was excellent, suggested that in singleton gestations with no history of preterm birth, yes, a cervical length of under 25 millimetres does not benefit from a cerclage. However, in women with a very short cervix, that is women with a cervical length under approximately 10 millimetres, there absolutely, is evidence for a cervical suture, okay? And I'm going to come back to this very shortly in my summary to tell you who should or who should not get a suture. The last group of women are women who benefit from a rescue suture, and this is essentially women who present with a dilated cervix with bulging membranes at 16 to 23 weeks gestation. And we have evidence to say that this type of suture is associated with increased neonatal survival and also a prolongation of pregnancy by an additional roughly 5 weeks. Now, I have had women that I have looked after who have come in at 20 weeks pregnant with, for example, a little bit of pelvic pressure. You examine them, their cervix is 3 to 4 centimetres dilated. That would usually confer inevitable loss of the pregnancy. And I've put sutures in women like this who've delivered at 37 to 38 weeks pregnant. So certainly anecdotally, I think it can be of great benefit. It is not a procedure that comes without risk. There is a reasonable risk of breaking the waters at the time of suture insertion. There's a reasonable risk of chorioamnionitis, and these women need to be counselled very carefully before this type of suture goes in. Having said that, given the almost inevitable poor prognosis of doing nothing, a lot of women want something done. The last group are other medical therapies. Both of these are essentially in trial phases at the moment. The first is Sulindac. So Sulindac is a selective COX-2 inhibitor. It's 16 times more selective for COX-2, and it may prolong gestation when with cervical insufficiency by reducing the amniotic fluid index, that is the Lycor volume, and therefore reducing pressure on the cervix. It does have potential risks, and therefore it's not yet used sort of in widespread practice. And we know that actually if used in late pregnancy between 36 and 40 weeks, it can have quite significant implications. It can prematurely close the ductus arteriosus, it can cause persistent pulmonary hypertension, renal impairment and necrotizing enterocolitis, and therefore we do not use it in the third trimester. It's currently, as I said, being used more in the trial setting, and there is a prospective study being done at the Royal Women's at the moment for which we're recruiting, looking at its usage in women who have a rescue cerclage and a cervix of under 10 millimetres. The other thing, which is the wonder drug in obstetrics, really is aspirin, and I'm going to come back to aspirin a bit later when we talk about medically indicated preterm birth. But essentially, based on studies which were done looking at reducing the risk of preeclampsia, they actually subsequently found as well that in women at high risk of preeclampsia, taking aspirin actually reduces their risk of preterm birth. And there is a study being done at the moment called the April study, and this will answer our question. This is specifically a randomised control trial which will look at the use of aspirin in the prevention of recurrent spontaneous preterm labour. So, to summarise, essentially, for spontaneous preterm birth, women with risk factors to spontaneous preterm birth really should be referred to either an obstetrician or a clinic or dedicated preterm birth service because of two things. Firstly, they get enhanced provision of expert care and the application of effective interventions for at-risk women. And it also, as I said before, alleviates anxiety in this group of women who are incredibly worried and concerned by previous obstetric outcomes, and it really gives them that continuity of care, which I think is really priceless in this setting. Who should get cervical surveillance? It should be offered to all women with a previous preterm birth, especially prior to 34 weeks, any woman with a previous mid-trimester loss, any woman who's had either a comb biopsy or at least 2 LETSs or ablative cervical procedures, any woman with at least 3 cervical dilatations, any congenital uterine malformation such as bicornuate, didelphys, septate, arcuate uterus, or any obstetric cervical trauma. Progesterone, and the dose that we use is 200 milligrams via pessary given knock day, should be recommended to all women with a cervical length of less than 25 millimetres, and it should be considered in all women with a history of spontaneous preterm birth. Who should get a cervical cerclage? It should be considered in any woman with at least 2 previous mid-trimester losses or preterm births, and this is history-indicated suture. Ultrasound indicated sutures should be considered in any high risk woman with a cervical length of less than or equal to 25 millimetres, or a low risk woman with a cervical length of less than or equal to 15 millimetres, or any woman with a dilated cervix at 16 to 23 weeks gestation. So I hope that's sort of an understandable approach to spontaneous preterm birth. Iatrogenic preterm birth is much briefer, and essentially what I'm going to do is just go through the most common indications for iatrogenic preterm birth and discuss whether or not there's any way that we can prevent them from happening. So again, this is another referral that I've received about a woman at risk of medically indicated preterm birth. This is a lady who's had 2 pregnancies complicated by severe preeclampsia. So in her first pregnancy, she developed HELP syndrome at 36 weeks, requiring delivery. And in her second pregnancy, at 28 weeks, delivered in the setting of a major placental abruption with severe preeclampsia. The baby unfortunately died at 6 days of age in the setting of a severe intraventricular hemorrhage. So, looking at preeclampsia, what is the risk of recurrence? Well, the Semans guideline, if ever you're looking for an excellent guideline on the management of hypertension in pregnancy, this is it. It's an Australian publication, and the most recent update was in 2014, and it tells us that women who've previously had preeclampsia have a 16% risk of recurrence of proteinuric preeclampsia, and if you have had a severe preeclampsia at less than 28 weeks in a previous pregnancy, your risk of preeclampsia in the next pregnancy is actually about 55%. So what can we do to prevent preeclampsia? The answer is aspirin, okay? And I'm sure a lot of you see pregnant women on aspirin to reduce the risk of preeclampsia. Our best evidence thus far is from the ASPRI trial. So this was a trial published last year in 2017, and it was a randomised controlled trial which compared aspirin to placebo in women at high risk of preterm preeclampsia. They randomised women to either 150 milligrams a day from 11 to 14 weeks until 36 weeks, and what they found was that preterm preeclampsia, which was the primary outcome, was reduced by 62% in women on aspirin. And the incidence of preeclampsia actually prior to 34 weeks was reduced by 82%, so a very impressive number. When should aspirin be given? Well, there have been a couple of studies which suggest that there is diurnal variation in the efficacy of aspirin, and because of that our current recommendation is that aspirin is given at night. So 150 milligrams given at night time is the best dose and timing to give aspirin. Who gets aspirin? Well, the best guidance we have in this regard is the NICE guideline. So this is a British guideline, and essentially they tell us that aspirin should be given to women who have at least 1 high risk factor or at least 2 moderate risk factors for preeclampsia. High risk factors are a history of hypertension in pregnancy, any chronic kidney disease, any autoimmune disease like lupus or antiphospholipid syndrome, any pre-existing diabetes, either type 1 or type 2, or any chronic hypertension. And moderate risk factors are primiparity, advanced maternal age, that is any woman who's pregnant over the age of 40, any interpregnancy interval of more than 10 years, a BMI of greater than 35 at booking, a family history of preeclampsia. Now, family history applies to a mother or sister that had preeclampsia in a pregnancy, or any woman with a multiple pregnancy. The other medication which has been trialled in the setting of risk reduction for preeclampsia is calcium. And essentially meta-analyses of placebo-controlled trials in low-risk women with adequate dietary intake of calcium suggest no benefit. On the contrary, in high-risk populations with low calcium, there does seem to be some benefit. So the overall consensus is that it should be recommended in high-risk women with a low calcium intake. Now, to be honest, I don't ask every pregnant woman who's at risk of preeclampsia what her calcium intake is, and I must say if I have a woman who is on aspirin, I put her on calcium as well. So they go hand in hand for me. Another common indication for iatrogenic preterm birth is intrauterine growth restriction. And again, the only intervention that we know to potentially be effective in reducing the risk of fetal growth restriction is aspirin. And if we commence it prior to 16 weeks, in high-risk women, the risk reduction is up to 45%. Placental abruption is another common cause, but unfortunately, despite what a number of obstetricians will tell you, we do not have any evidence for any intervention to reduce the risk of placental abruption. A lot of people use high-dose folate, they use aspirin. There's not known to be any harm from using these, but equally, there's not known to be any proven benefit. One area that we can work on though, and this is where I think general practitioners need to become heavily involved, is in managing women who have chronic medical disorders. And we know that women with chronic medical problems like renal impairment, pre-existing diabetes, autoimmune conditions have a much higher risk of preterm birth because of deterioration of their conditions in pregnancy. And the best time for us to actually act on this is pre-pregnancy. So if you have women who you think might be planning families who have medical conditions, it's best for you to optimise them, but also really to consider referral to an obstetrician who specialises in high-risk pregnancy prior to conception so that these sorts of things can be optimised. And in fact, managing these reduces the risk of both spontaneous and medically indicated preterm birth. Second last thing I'm going to touch on is multiple pregnancy. Now, although multiple pregnancy doesn't account for a huge number of births in Australia, it accounts for 17% of births prior to 37 weeks and 23% of births prior to 32 weeks. And when we are thinking about reducing the incidence of multiple pregnancy, there are a number of things that as obstetricians we need to consider. And they are when we are allowing a woman to have or guiding a woman through ovulation induction, we should probably be starting with clomiphene rather than gonadotropic medication. In women who are undergoing ovulation induction, I think it's important to track follicles throughout the cycle, and if there are an excessive number of follicles, then I either suggest conversion to an IVF cycle or cancellation of that cycle altogether. When using IVF, most people now aim for single embryo transfer, and fetal reduction should always be remembered as an option for women with higher order multiples, that is triplets or greater. The last thing to mention, and again, I think this is something where, as an obstetrician, I bank heavily on the support of my general practitioner colleagues, is in encouraging any patient that smokes to stop. And we know that there is a moderate dose-dependent relationship with the risk of preterm birth. This is because not only there is an increased risk of spontaneous preterm birth, but there is a higher incidence of placental abruption, placenta previa, of preterm pre-labour rupture of the membranes, and of growth restriction. And smoking cessation should always be encouraged. So, in summary, what should we do? Aspirin at a dose of 150 milligrams nocte, plus or minus calcium, or in my case, plus calcium, should be recommended to women from 12 to 36 weeks gestation if they have a high risk of either preeclampsia or growth restriction. And this is any woman with at least one high risk factor as per the NICE guideline, at least 2 moderate risk factors as per the NICE guideline, or fetal growth restriction in a previous pregnancy. I encourage you to refer any woman with a chronic medical condition that predisposes to preterm birth to an obstetrician who is adept at managing high-risk pregnancies, ideally pre-pregnancy, for optimisation and future pregnancy planning. And once again, I strongly encourage you to encourage your patients to stop smoking. Thank you very much for your time.